and welcome to Varn Blog. And today I'm with Beatrice Alder-Bolton, co-author of Health Communism, co-host of the Deaf Panel podcast, and general health and disabilities advocate. I would probably say that's fair.
Yep, I'd say that's accurate. Thanks for having me. It's great to be here.
Well, thanks for coming on. So there's a whole lot in this topic, and there's a whole lot that can come up in terms of your book, Health Communism. There's all kinds of new issues with disability rights, which I feel like is something that's only getting more complicated by the day, in both good and very bad ways. So I wanted to start off, though, with, an assumption from the introduction of your book, which is not yet out by Verso.
No, it's out in about 30 days, October 18th. Yeah.
Okay, so it's coming out. Is that capitalism seems to have a particular weakness in health and healthcare. And that's both somehow transparently obvious to everyone and yet also a contested assertion. Can you go into what that weakness really is?
Well, I think if you go down to just sort of the very kernel of what labor power is, right? That's your health. Your capacity to work is what your capacity to sell your labor is. So fundamentally speaking, like what we think of as health is it's a much more complicated thing than just what's on the medical chart at your doctor's office or what prescriptions you take or what diagnosis you have. It's more this perspective of where you are within a whole range of different forces that are intersecting. Like, for example, like you are not going to be able to be like a stronger worker, quote unquote, if the air around you is being poisoned by nearby factories. If we're in the context of COVID right now, right? If you are someone who's being forced to be exposed to COVID over and over in the workplace and you don't have sick days, right? And you're in this position of basically being told, okay, you can either work through sickness and maybe spread this disease that you know might not hurt you or your friends, but could hurt someone else. You go destitute, right? You work through being sick. You stay home from work. You have the situation where we have people who have been penalized, right? And this has come out in the context of the rail strike as well. So you can't actually have labor power to sell if you don't have some kind of control over the social determinants of your health. And that's just like as simply as like having housing, having food, having clean water. But it's also more complicated, right? And so one of the things we try and show in the book is that what we're told to think of as health and healthcare is really shaped by what's become a good billing code for the insurance industry. And what is actually health and healthcare and what is actually our health is a much more amorphous and difficult to define phenomena, but it's also the central core of what capitalism needs, both in order to reproduce itself, but also it's at the core of everyone's own individual labor power. And I know that might sound like really abstract, but fundamentally, like if you go back to some of the earlier frameworks, particularly in the labor movement, in the United States, you have things like people's limbs being valued by the pound, right? Let's say you're working on a railroad, you sever a couple fingers, that then sort of was actuarialized and tallied up. And so one of the ways that we've constructed all sorts of benefit systems, all the sort of welfare programs that the left has historically been fighting for a long time is like based on these moments where our bodies are commodified, right? The welfare system is about supporting a body when it sort of breaks out of the bounds of the marketplace. And essentially, health at the end of the day, if all of your workers are sick, then there's no surplus profit that you're going to extract, right? We're not looking at a kind of world where tomorrow we're all going to be replaced with robots. This is like the reality. Like, we can't make all of the workers sick at once, right? Society will collapse. And I think in the context of COVID, what we've really seen is that one of the big myths is that we like to pretend that health's really no big deal and that it's our personal responsibility of each and every individual. But it's also capitalism's job to maintain at least a bare minimum amount of health in order to keep the labor supply moving forward. And there is a possibility of hitting a point where there's too much sickness, too much death, that we can hit some sort of tipping point. And I think that's sort of what we're arguing towards in the book.
There's a whole lot there, and I do really appreciate people being exposed to Marxian categories, not just the context of money or indirect labor power. One of the things that it strikes me is a fundamental, to use Marx's terminology, contradiction, but I'll use normal people terminology now, tension between health and health-related factors as externalities, which is the way they're normally talked about in neoclassical economics. And then the concepts around labor, because you're absolutely right, a diminishment of health is a diminishment of labor power. And we have seen that in the last 3 years. I mean, we've seen 6 million jobs go unfilled through vacancies since COVID. And while there was a lot of talk of the Great Resignation, recent demography on this seems to indicate that most of that was either people retiring from fear of getting sick and dying, leaving the workforce to be able to do childcare in the case of a lot of women, and people having long-term disability from things that happened during the COVID year, some directly related to COVID, some not. But that seems to be where the massive contraction of the labor force has come from. But let's add to that something else, is we've also seen a massive contraction of worker productivity. Now, as a communist, I hardly care about that in some ways. But it is evidence for what we're talking about, because even the people who are going to work are much less productive. And this seems to be true whether or not people are in person or doing remote. Like this productivity decline is generalized. So
yeah,
oh,
sorry, I didn't mean to cut you off.
No. It just seems like pretty hard evidence for the initial argument. I
mean, it's ridiculous to expect people to be able to work under the social and political conditions that we've been under for the past 3 years. I mean, we are told to pretend like everything is normal and there's no virus, but in the United States, there's still 500 people dying a day. And unfortunately, we've reached the point where, because of the open Biden Beyblade strategy, so many people have gotten COVID because of the Omicron wave, because of this transition to a kind of let it rip, it's okay, get vaccinated, but also get infected, you'll be fine, everything is mild. The kind of density of illness that we have all experienced is so unprecedented. I can't underscore this enough, right? Like, normally during a regular flu year, right, the season doesn't last all year long like this, right? Like, we don't experience flu all year long. A bad year of flu deaths is 50,000 deaths. That's a fraction of what we're looking at with COVID, even if we stayed at 500 deaths a day, right? And there's no guarantee on any of this. And it's ridiculous to expect that we could be putting people through so much sickness and suffering and loss and trauma and financial stress, since all of the social safety net supports that were put in place in the first year were rolled back. We're supposed to expect people to be like acting normal at work and normal output. I mean, it's ridiculous. It's ridiculous. And as you're seeing with the railroad strike and the situation, I think, with a lot of people who are working in the airline industry, it's there's no question ever of like, oh, do we need to sacrifice the kind of the like goals or the quarterly goals of like how much we want to be moving in terms of volume. And it's as if there's an infinite supply of ready, able-bodied, healthy human beings that just can be slotted in as the next worker falls. But the fact of the matter is that we're all people and we have lives, and we're not replaceable, right? And there is not an infinite supply of ready, healthy, quote unquote, able-bodied so-called workers ready to fill these positions. And so there's a kind of, there's a fundamental break there between the way the system says that it works and the way that it actually operates, which is that it actually cannot immiserate us to, an endless capacity. We cannot increase productivity to an endless capacity. And there are limits, even to capitalism.
I think that's a pretty fundamental point. And I think one of the things that your book also brings up in the first two chapters, and we can go into this a little bit more in detail, is that social democratic answers to healthcare, whether they be socialized medicine or socialized insurance, both of which are common outside of the United States, neither of which are common in either the United States or people would be surprised, or China, as I point out all the time. But that even those kinds of answers and the things you hear from, the Bernie Sanders end of the left, while they would be massively preferable to what we're currently dealing with, would still not answer this question. And they haven't been able to. I mean, the socialized medicine was not actually one of the key vectors for how well you handle COVID. Right. So what do you see as the problem there?
Well, I mean, I think if you're going to truly pursue a system of socialized medicine, it has to have two things. And one is that it actually has to be internationalized. It can't be a national health service. Mm-hmm. And two, I think that, and, this is a quote that we have in the book, but Vicente Navarro says that the NHS is not a socialist, a socialist island in the middle of like capitalist UK, right? Mm-hmm. We can fundamentally set up these systems that attempt to socialize the cost or the payer of medicine, and we can do that under capitalist frameworks. But if we want to set up systems of actually redistributing resources and allocating care in some sort of way that was reflective of need, was reflective of our capacity, right? And I think the vaccine situation, the global vaccine apartheid, is a really good example of that with COVID. There is no reason for global intellectual property to apply to pharmaceuticals. And it's really important to recognize that some of these structures of the kind of nation and the state and the border, that they sort of stand in the way of distributing these resources as well. So if we're going to pursue true socialized medicine, it's going to have to be a bigger, longer project that's actually kind of looking and thinking at the scale and at the sort of level of collaboration. I'm not talking about like people from the US coming in and being like, we're going to fix your healthcare like ours. Like, there has been plenty of that. It's more like, let's listen to you and like, let's talk about what you need and let's talk about what we need. And like, let's talk about how our movement goals could maybe not like step on each other's movement goals, right? These are the kinds of things that are long long questions and are going to be long arms of political struggle, but we're never going to approach the kind of health system that we actually want, or I think that many people on the left actually want, within the bounds of a capitalist state, right? There is this sort of fundamental constraint that's always going to turn us towards something that we talk a lot about in the book, which is the economic valuation of life. So absent sort of addressing this fundamental way that we value life according to labor capacity, according to labor value, then it's difficult to actually socialize medicine. We're only socializing the costs, right? But if we want to actually redistribute care and address some of the underlying problems, like some of the problems of racism in medicine, or some of the problems in terms of the way that expertise has been hoarded for sort of generations within certain professions, and the kind of debt burden that, you know, people who are doing this training are asked to put on. Like, there are a lot of ways that we could do healthcare way beyond who pays for it. But I think it's very important to recognize that so far we have been kept within the bounds of talking about the pay for question. Mm-hmm. And so what we're asking in health communism is we're asking people to say, okay, like, I'm working on the payer question. Like, we're all working on the payer question. What next? What's beyond the payer question? You know, what is simply like bigger than these small reforms that we've been able to, you know, see kind of iterate every couple of years. You know, there's a lot of support here, you know, in the last like decade for Medicare for all, but you know, Medicare for all would do a lot, not just for the United States, but towards sending a message to the people who are trying to privatize the NHS, towards sending a message to people trying to privatize the Medicare system in Canada. You know, I think if we start rethinking some of our fights for healthcare, rejecting the kind of border framework that a lot of these more nationalist-oriented socialized medicine programs have taken on, I think that that's kind of where the future of our organizing should be going.
I think that's a key point, and it's something that I have experienced firsthand in the need internationally. So I lived in 4 different countries in about 9 years. And since I was a legal resident in all those countries, I had access, if they had it, and one of them didn't, to some form of socialized medicine. But socialized medicine, and for example, in a lot of Latin America, that isn't preventative, is, for lack of a better word, a joke. Like, it really is a horrible shit show that right wingers say it is. Now, if you go to a place like South Korea or France or any of these places that have socialized insurance, it's still not ideal. You can still be denied for inability to pay, although the amount paid is, you know, 1/100th of what it would cost in the United States. But it functions very, very well. And the results are better than the US, frankly, in almost every key indicator. Now, the reason why the Latin American models, and I could think of a couple, Mexico, which I've experienced, Colombia works in a similar way, Chile works in a similar way, have largely not been successful, is that while they can command labor, and they do, they can get good doctors into those clinics, they can't command resources. They just don't. The state doesn't have the ability to purchase them, and they don't produce enough of them internal to the nation state for it to be granted. There's also some indications that there's not a political will in some cases, but that apparatus exists. It exists in Europe and the US. It exists for different reasons in Europe and the US, but it exists in both countries. And so when people hear these things, they are often surprised that I would say that oh, like Latin American, medicine is not great. Well, it isn't, except for there are issues where it actually is better. Vaccine acceptance is one of them because doctors and nurses tend to be more dispersed from the community, and there's not as high of a social class distance between them and living standards, meaning that people know them and trust them. And so the acceptance of things like vaccines is much higher. So that's a success. And another key thing that I've really looked at is Cuba, and Cuba's the odd person out because they have all the financial problems plus because of the hard embargo by the United States, and yet they really have, because they do not have a private sector at all, done research and innovation in ways that have pushed the system with very few resources to be much more successful than the U.S. based purely off of labor power and ingenuity. And imagine what you could do with those doctors if they had U.S. style resources.
Right.
Just,
imagine what we could do if everyone was collaborating.
Right.
And not fighting for the research grants. Right. I mean, and I think this is one of the things that we try and fundamentally point to in the book, particularly towards the middle. There's a chapter called Pharmacology and a chapter called Border, where we talk about some of the things that that are sort of truisms, I guess, about why drugs are scarce in certain parts of the world and abundant in others. And really, the fact of the matter is, at the end of the day, this is not like, sometimes when you talk about pharma, it can sound like conspiracy theory, right? And I'm someone who's chronically ill. I'm on a lot of medications. I would not be here today without Roche and Pfizer.
Mm-hmm.
But that doesn't mean that they're not intellectual property cartels who'd say, oh, this country, they're too poor. They don't have the sort of technology in order to develop this drug. This is a drug that's made for the United States. We give some really specific examples in the book about scarily recent examples. For example, one 2013 during the Obama administration in India, they following the TRIPS waiver protocol, right? They got permission to get a compulsory license to make their own version of a cancer drug that was really expensive to import, and they wanted to have, a domestic supply. The United States stepped in and threatened sanctions and leaned on India to get them to stop. And despite the fact that the TRIPS waiver allows things like this to happen textually, right? Functionally, in the enforcement mechanisms, like in the situation with Cuba, like in the situation with India, you see the United States stepping in and using its sort of international trade cudgel towards not the benefit of the global public health, but towards the benefit of maintaining the property regime of the pharmaceutical company. Right. And fundamentally, the CEO, this was a bear drug. The CEO at a like Financial Times conference, it always happens at one of those like Financial Times, conferences where they're on, like a horrific stage, and he's sitting on the stage and he's like, we didn't make those drugs for those people. We made those drugs for rich people. Those aren't drugs for the third world. Like there's no subtext, right? Like the idea of pharmaceuticals as a kind of really important property regime that's mostly sort of controlled through the United States and companies that have ties to the EU and the US. And, the United States also has kind of like the premier drug certification agencies with the CDC and the FDA, and this kind of idea of like oversight. And it sort of projects this idea that like, oh, well, this is this great land of innovation where this is the only conditions that we can see innovation happen, right? And if we take money away from these companies, then how are they ever going to develop the next wonder drug? But for all of the money that goes into pharmaceutical companies, most of the new drugs happen and are discovered at a much smaller scale and then are sort of bought up by the bigger pharmaceutical companies. So we kind of have this relationship now where like the federal government of the United States acts on the international stage, not in the interest of people's public health, but in the interest of maintaining these sort of important trade relations where it comes to pharmaceuticals. And so if we're going to try for socialized medicine and we're the United States, we have to do way better than having a list of 100 drugs that are going to be bargained for, right? You know, it's kind of amazing to see the lengths that the US government will go to protect the property of a pharmaceutical company and how little they're willing to do to make sure that people on Medicare can afford their drugs, right? And sort of these fundamental imbalances and frankly, the values of what our institutions are actually here for and meant to do, any project towards socialized medicine needs to deal with that. We can't just deal with the payer. The payer is only one part of the problem. You know what I mean?
No, totally. I can give you a couple, just more examples. This one's from my own life. My ex-wife had a severe form of skin cancer. And the only treatment that it would respond to is a fairly newly approved immuno treatment. That treatment, there is a monopoly on that patent. And that treatment, while the drug company would offer to reduce the price by half, the price for that treatment is $100,000 a dose. And only 3 countries that I know of can even get it. And so that's the United States, Germany, and so I guess that's supposed to cover EU access, and I think Japan. And even if they had the money, which they don't, small countries like Egypt couldn't get it. So unfortunately, we sent my ex-wife back to the United States from Egypt. And then during the same time, they couldn't even get chemo drugs because of in Egypt, they did what the IMF and China simultaneously advised them to do, which was to float their currency for more currency sovereignty. And they immediately had a currency crash by removing the currency controls. And they could not afford nor get chemotherapy drugs for about 6 months. And so, I was already a radical by this time, but that was one of these things that was like, I absolutely am now. Like, the absurdity of the situation. To go even more into that story, that we had good insurance. We had it from a British provided insurance company that had some deal with one of the U.S. insurance companies. It was supposed to be covered, and they tried to deny it. And basically, the owner of our school, who is some Lebanese guy who I don't know what kind of power he has, but he threatened the insurance company and they paid it out, got it paid out. But the thing is, for the insurance company to even follow its own protocols needed a threat from a pretty high level capitalist to do what we pay it to do. I mean, so it was kind of amazing to watch that in real time, because it was absolute proof of the kind of things you were talking about. As I was reading your book, I kept on thinking about, I've encountered this. I've encountered this. I've encountered this. I've seen this in real life. Like,
the book worked. I'm so glad to hear that.
And it was actually nice to like, I can now put this in Marxist terms and people can shut the fuck up. So not called as liberal concerns. But one of the things that I was thinking about as I was reading through this book is this thought of surplus population. And this even comes up, in places like Canada and the Canada National Health Service. So, like, for example, one of the things where I say the Canada National Health Service often isn't great is on dealing with rare cancers.
Terrible.
Yeah, they're awful at it. And it's because they basically assume that the cost to to life ratio just isn't there. And if you get somebody who makes a conservative argument about Canadian healthcare, this is one of the few points they can bring up that's real. That led me to thinking about the way even countries that have socialized medicine, quote unquote, treat, quote, surplus population. And one things we've seen in both the US and Canada during COVID is we basically have treated everybody over 65 as expendable.
Yeah.
And that's not unique to the United States. Have you seen similar trends?
Yeah, I mean, it's not just people who are older too. It's people who are in particular intellectually or developmentally disabled. Mm-hmm. People who live in group home facilities of any kind, people who are mad, people who are immunocompromised. We did an episode of Death Panel, which is the podcast that I co-host, where I interviewed a guy named David Stedson, who's a researcher based in Sweden. He's Australian, but he's lived in Sweden for 22 years. And he was a co-author on a big study looking at the political response to COVID in Sweden. And what happened was horrifying. I mean, this is not something that is unique to the United States or unique to Sweden or unique to Canada, but what happened in Sweden was especially obvious and heinous. And it came out in official reports from the government that many people who were older, who caught COVID early on, were not treated. They were offered palliative care, and many times the family was not told or notified that that was the plan. And, there is a very long history in our global societies, right, of there being people in the world who are disposable. And there are a lot of reasons why we tell ourselves that those people are disposable, and there are a lot of myths and justifications and a lot of different types of disposability. But I think the kind of pressure of the pandemic, as I was saying, this is like a level of sickness. The concentration of sickness of COVID is really what's kind of most novel about it. And that's the thing about the pandemic I feel like people don't get. But, the decision in Sweden was basically like, well, these people are kind of near death anyways. Let's just make them comfortable and clear up beds for younger people, right? And there's this kind of idea of like people being having an expiration date, right? And where those ideas come from is something that we try and show people in the book. It's something that we try and talk about very explicitly, because that kind of disposability is key to a lot of socialized medicine systems. I mean, right now, you brought up the example of Canada. In Canada, recently, there's been an expansion of the medical assistance in dying laws. Part of the justification for it is that not only should people who are terminally ill be allowed to sort of participate in this program, but people who are mentally ill or just sort of chronically ill or disabled in any way. And while they swore up and down, oh, this is never going to result in someone essentially sort of choosing this option based on cost, it became immediately clear that the sort of fiscal side of things was very present. I mean, from anecdotal reports immediately of people being in the hospital, being kind of coached into, well, are you sure you want to be a burden on your family? And there's this kind of idea of this disposability being a necessary component of any kind of sort of society. And that's something that we try and sort of write against. I mean, even like within Marx, like the surplus class is an idea, and it's mostly referring to people who are unemployed. And he does, you know, like they talk about the people who we might think of as being like surplus, people who are disabled, who are out of the workforce for whatever reason more permanently. But he doesn't even like consider them. There's no consideration of them as sort of being part of the economic calculus. And there's like footnotes and letters somewhere that basically say like, well, this was like a simplification for time, and we really didn't know what to do with this, and we were doing our best, you know. But there have been very few people who have tried to pick it up and say, okay, well, how do we actually like not just think of the surplus class as being a surplus reserve army of workers, but as an actual class power in and of itself? And part of that really relies on the work of a theorist named Marta Russell, who passed away in the mid 2000s or 2010s rather. And she, you know, she really worked with the idea of something she called the money model of disablement, which was the way that people who are not workers also become sites of labor production, whether that's as a patient in a hospital, someone who lives in a nursing home or a long-term care facility, or even the frame is actually extended to other facilities like group homes, prisons, or jails, anywhere where someone, you know, or a facility would be receiving like a per head fee from federal, state governments or whatever. So we see this sort of constant, economic relationship, right? Where we're told, okay, there's this surplus class that's like fully disposable, and yet the surplus class exists throughout the economy in many different ways, just not always as a worker.
Right. Well, I mean, the idea of labor surplus is I think one of the most fraught elements of Marx, and one of the things I always point out to when we talk about disabilities in Marx, he has the right attitude. It's to each of their own ability, from each to their own ability to each of their own need. And he mentions that you can't pay fairly because you have to provision a social surplus to take care of the disabled. That's 3 sentences in the Critique of the Goethe program, which he didn't publish in his lifetime. And that's it.
Yeah. I think the like accusation of Marx being ableist is a huge stretch. Personally, I'm willing to die on that hill. I don't think he knew what to do with it.
Mm-hmm.
But I think he cared about it, and he critiqued. I mean, he and Engels are making fun of Malthus so much in their work, and Malthus's whole mission in life was to find better ways to dispose of the surplus class. I think fundamentally this was a question that was too big for Marx and Engels, because it's a hard one.
And I think it's interesting also when you talk about the provision for this in terms of actual socialist planning, because I can think of 1 or 2 groups that picked up that line in Critique of the Goethe program and actually tried to deal with the elderly and the disabled by allocating them, you know, some essential part of the social surplus. But even in those models, that allocation is actually democratically voted on, and which would still make it somewhat precarious. I also do not have a good solution for this problem. It's just something that I have also thought about, and I push back on people saying that Marx is ableist because he does mention it. It's just it doesn't come up a lot. It and the other one is lumpinization are the 2 areas where Marx and Engels like have some answers, but then start seeing problems that they don't have answers to, and die before they figure it out, basically. But I think it's more than any 2 people can do on their own.
I mean,
Right.
are we really going to hold them responsible for having all of the answers?
Exactly.
That's a lot of,
Um,
I thought we were kind of like over the great man theory of change on the left and that we could make room for more answers. But no, I think you're right.
Yeah, I would love for us to be over the great man theory of change on the left. But if anything, Twitter has convinced me that not only has it not gone away, but it's actually probably gotten a lot worse. No, the Marta Russell parts were actually interesting, though, because there is another dialectical tension or contradiction, as you point out, between disabled as surplus population and disabled as labor generating off the surplus. They can't contribute to the surplus, but they do contribute around to the spread of capital. And that contradiction, actually, until I read your book, had not occurred to me. Okay. Now, what had occurred to me that is fundamentally related is in the US, when I think about one of the reasons why we don't have socialized medicine that I don't hear socialists usually deal with very realistically, and this is why I like your book, Health Communism, for a variety of reasons, and this one's actually political economic more than just health policy, is that if we actually socialize medicine efficiently in a capitalist system with a socialized medical sector, not only would that still be subject to capital, but it's also going to get rid of a ton of middle class jobs that subsist off of the social surplus, more or less. Like they don't contribute to it, but they do subsist off it. And unlike a lot of people on Twitter, I don't have any moral judgments behind that. But like, think about all the people who service insurance, all the people who service coding, all the people who service billing, all the people who service paperwork, all the entire administrative bloat and cost disease. Well, if you actually fix that problem, you have one of the few growth sectors in the U.S. economy removed overnight. So it's
I mean, it's billions and billions of multiple industries. I mean, what it would require is a totally new political economy of health.
Mm-hmm.
What would result from it would be not just a couple reforms, but a reformation structurally of what these many industries are for. Let's take, for example, nurses who are hired by insurance companies to be part of the process of denying claims, or physicians who are hired to be part of the process, or even people just in that call center, right? Like if we redirect that one chain of people and we say, okay, rather than you being in charge of denying claims, this is a team of people that tries to facilitate people getting diagnosed and coordinate care, who make sure that they're getting into the specialists that they need to be getting into. These are labor capacities that we have regardless, right? And we can do with them what we please, theoretically. We have decided to make work for ourselves. We have decided that disease exists with a code because of a billing relationship that code has. And people form their entire identity around that billing code. You know, like, yeah, it's a disease, but it's also a billing code, right? And I fundamentally am so frustrated that, you know, these kinds of relationships that I have with all of the people in my life that help me as a body that's like modified and needs a little bit more whatever, you know, be it medical attention, resources in terms of pharmaceuticals, nursing, workplace accommodations, like those things are jobs for other people, right? And so we can take these frameworks and we can reorient all of these energies that go towards essentially enforcing austerity right now towards so many different things. I mean, I think another great example of this is the entire Medicaid estate recovery industry. Do you think people want to go to work and call people and be like, oh, so sorry that your relative died. I'm calling from the state. We're going to take your house. We're going to take their house because we're going to pay ourselves back for the long-term care, for the nursing home your loved one was in. This is an entire industry. States spend money to hire people to be essentially bill collectors in order to self-fund the Medicaid. You know what I mean? Like this is a decision,
right,
to set it up this way. And actually, one could argue, what are the negative social determinants of health of working in a job where you go to work every day and that's what you're doing, right? How does that make your life shorter, more cruel, more brutal? If that's what your job is, how much better could your life be if your job was actually just about trying to help people get the resources they need? You know, it's so much energy wasted.
Yeah. Again, when I was reading your book, I kept thinking about encountering this in my life. I remember sitting down with my ex-wife before I put her on a plane to Egypt and going, well, if you die, they're going to reclaim everything we own. So I'm not coming back to the US ever if that happens. And just sitting with that, because I'm like, well, because I could potentially be on the line for your $500,000, and I don't want that on you. I don't want you thinking about that. Yet that's a fiscal reality, because you can inherit as a spouse medical debt, and medical debt is non-dischargeable. I mean, that's particularly brutal. This is an obvious observation, but it's always been wild to me that the two things that you can't discharge in bankruptcy are two things that there's no argument about moral hazard about, because like even from the neoclassical standpoint, it's kind of barbaric,
right?
So it's something that I think a lot about. But I have been thinking a lot about surplus and what we accept as surplus, not both nationally and internationally. And one of the things that I worry about is that we have planners on foreign aid in light of climate change, which people might not immediately see as part of this book, but it absolutely is, who are going to be short shrifting aid to places like Pakistan. In order to, Palestine, any place actually, where they can reduce surplus populations, who they might see explicitly as surplus populations. I mean, you almost get the idea that there's people salivating over Bangladesh going underwater. Like,
I mean, it's like all these like effective altruism motherfuckers who say like, oh, we're sending the aid where it's needed, but you know, also depopulation isn't a terrible thing. You know, that's a value judgment that declares whole nations surplus.
Yeah, and I think we're going to be moving into a period where we're going to see more and more of that explicitly. I think these floods in Pakistan, which I'll just say this for posterity's sake, which we're recording in the middle of September, it's probably released in early October, but the beginning of this month in September, dehoused 1/7 of the population. More people, and I want people to, like, when I say this, I don't think they get it. More people were lost their homes and became vulnerable to illness and sickness and relocation in those Pakistani floods than the entire population of Australia. All right. It's more people than 90% of the entire population of Canada. And so for me, we do have to think about these things in an international matrix. And I guess to kind of come back to another point, it's not just out of altruism that we should be doing this, because we're never going to get rid of diseases like COVID or be able to run a effective vaccine program unless it's global, because if you create pockets of unvaccinated countries that then people travel to and get new strains of the disease and bring them back, it also kills the first world vaccination program. Like, that's not hard to figure out from an epidemiological perspective. It's like something you can kind of see off of the back of the napkin kind of equations.
Oh, yeah. I mean, you don't need to see the future. You don't need to be an oracle or whatever. Nobody's Cassandra. Like, this is all very obvious shit, right? For years, we've had the IMF fucking around in other people's healthcare systems all throughout the globe, taking little, American markets and trying to reproduce them. And what we've ended up with is a system that pretends that like each marketplace is hermetically sealed and doesn't have any sort of impact from the other ones, other than some sort of abstract idea of like immigration, like coming in and overflowing one system. And this is literally, essentially, this is the pinnacle of like global public health security discourse, right? Is like, how are we managing migration? People that are migrating for climate or migrating for healthcare, like, well, we have to stop treating countries like they're, in their own little bubble, right? Like, we have to stop pretending like what happens outside of our walls doesn't affect other people. And that's a very, unfortunately, radical idea. That even in comparing the US like aspiration towards Medicare for all to the Canadian healthcare system, with the sort of things you've laid out so far, just in this episode, just between the MAID example that we gave, also, by the way, like, prescription drugs aren't covered province to province in Canada. It's a really different situation. What do we do to like Canadian comrades by saying that we want a system as good as theirs? How low of a fucking bar is that? Like, that's reflective of policy that ends at a border, that sees it as a zero-sum game of US needing to get its own to get as good as Canada. Shit doesn't work like that.
Yeah, I'm not aiming to get the NHS, for example. That's not my goal. Like, I would like to think we were more ambitious than that, since we have the production capacity for a lot more than that.
We have the production capacity to give the drugs that everyone needs to everyone in the world. We had drugs sitting ready to send to vaccinate people for monkeypox. We held on to them for national security reasons. Yeah,
I mean, one of the unfortunate things about your show is there's probably going to be no end of things to talk about, given the nature of capitalist medicine, which I guess is kind of an unfortunate benefit of the topic. I was thinking about monkeypox today, and I know that in liberal circles, Anthony Fauci has been made a hero and blah 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 blah. He's not directly related to this, but I was thinking about how in the immediate rollout to monkeypox, they made the same mistakes as they made with AIDS in the 80s. By, even though it is statistically somewhat true that you can get the disease from from intimate skin contact, and there are reasons why that would be more prominent in homosexual relationships amongst men. that it's not even, unlike AIDS, an STI. Like it's just close proximity contact. And you already saw within weeks, conspiracy theories running around about pedophilia rings because of the CDC's branding here. And one of the things that I noticed, and this sounds conspiratorial, and I'm also not a conspiracy theorist, but I am a person who knows that the CDC makes decisions that are political, is the close contact airborne notion was removed from the CDC's description of monkeypox on one part of its website, which is the part that's easy to access, and it wasn't on another part of its website, which is the part more likely to be accessed by professionals. Why on earth would they do that, except so that there be no push to have people stay home from exposure from fear, right?
Well,
I think I can think.
I think you can't rule out incompetence.
Well, that's true.
You can't rule
idiocy
out
is also a problem.
The unending drone of hegemony and bureaucratic administration, because I think the whole discussion around monkeypox is really fraught. Like, even among people who agree with each other on COVID, like, there's a lot of disagreement about what exactly is going on with monkeypox. And, it's interesting you bring it up, because I've been working on an episode on this for like 3 months now that actually is coming out on Monday. Where I talked to Dr. Kelezzo Makofane, who has been doing some community-led epidemiology work around monkeypox and access to care and testing and vaccines in queer and trans communities in New York City. But Kelezzo is a HIV/AIDS researcher, and he and I were talking. He was in South Africa at the time, and we were talking about the things that went wrong, because beyond the disagreements about what exactly is going on with monkeypox and how it's spreading, fundamentally, like, there are structural failures that are so readily obvious here. Some of the decisions that were made to prioritize not essentially, like, not a single thing about monkeypox, because of many different reasons, some of them being kind of homophobia, some of them being like I think a hope that it would just go away, structural incompetence. It's it's never, I think, one specific reason why these things go wrong in similar ways. What I think it is that actually much worse and much bigger, which is that our entire political economy is essentially oriented to produce these kinds of failures. Mm-hmm. That the priorities of how the CDC itself constructs itself, how the CDC is funded federally, how international funding. I mean, this is a disease that was endemic for decades in West and South Africa, right? All of these therapeutics that are going around in the US that we're fighting around, access to in the US, those were made with the bodies of people that were sick, years ago, mm-hmm. right? Those pharmaceutical products came from somewhere. It wasn't like COVID where we had to sit down and make something new. These vaccines existed, right? For all of our access problems in the US, it's not like monkeypox is not still endemic in West and South Africa. Mm-hmm. Are those people going to get access? And as Kelezzo was saying, he was like, it was great, I'm working on this project. We raised $100,000 in 2 days. He's like, but if I was working on trying to raise money for HIV for Black men in the South, it would have taken me way longer. Mm-hmm. I probably would have never raised that kind of money. And ultimately, so underlying what might seem like individual instances of maybe bad actors, conspiracy, you know, this is hegemony, this is how things work, when the fundamental way that we structure our society is around valuing a person as an economic kind of token, as an object, right? The economic objectification of like the individual is ultimately like what liberalism is. We talk about it in terms of freedom, but it is about creating an economy of society. And what we need to do if we want to survive climate catastrophe, right? If we want to live with COVID, is like, it's much bigger than any one organizing project or any one reform or any one campaign. You know, it's about, I think, everyone sitting down and needing to like really think through and understand how the economic valuation of life underlies so many of the different things that we're working with. And so our hope in health communism is that we can kind of show people a lens, like, okay, like here it is, here's how to notice it. And our hope is that people can take that back into like what they're working with, because it's not like this stuff is bound within healthcare and stays there, right? It's within education policy. It's within criminal justice, it's within housing policy, within zoning policy, within the way that we, you know, put our budget together federally, within the way we fund the WHO. Like, this is a concept that pops up everywhere. It's as fundamental as the principle of, you know, the market and capitalism itself.
Right. I mean, that first chapter in your book makes it absolutely clear that this is a primary contradiction. It's not one that Marx and Engels spent a whole lot of time teasing out, but is absolutely obvious from just thinking about, well, if the abstraction of a relationship is what liberalism does in commodities, and we reduce our labor power to an abstract commodity, then we are reducing people whose physical condition underlies that labor power also to an abstract commodity. And the fact that there's ever been actuarial tables makes this apparent, you know, abundantly obvious.
So many, actually. Yeah. So many.
So, you know, I'm going to we're going to start wrapping up. I have two more questions that are kind of big. So, I really like this point about the radicalness of the system. One of the things that I've been worried about in the resurrection of socialism, in quotation marks for my listeners, is that the vision of socialism often on offer is actually often without people even realizing it, because they'll talk good talk on borders or whatever, heavily nationalist. It is methodologically and politically nationalist in orientation. You might get some very facile notions of internationalism emerging out of it, but not even talk of, maybe you'll get talk of like electoral strategy coordination, but you don't have the talk of like, we have to coordinate policy at a world level, except when you talk about climate change. And what I like about your book is it makes it very clear, no, we should have been talking about this in terms of healthcare the entire last 200 years. And so that's a big reorientation, but it is also larger than healthcare. Every one of these things fits into a large and frankly dangerously complex system that, if we do not simplify, will collapse. I was thinking about in your answer about monkeypox, because like you listen to any narrative of AIDS, and I've listened to a bunch, right? And we're always debunking how, one narrative was probably wrong, the monkey blood vaccine theory, the patient zero theory, etc. But there's no like question about like, well, we can't narrativize this because the number of fracture points in our current system would make it impossible to narrativize. There is no way, I think, you could get to a true epidemiological narrative of AIDS, for example, that would actually cover everything that happened for that crisis to have happened in the 80s.
I mean, anyone saying that they can like find a patient zero is just lying. You know what I mean? Like that's a rhetorical construction. That's a theoretical idea of how disease works. We have no way to prove that's what's happening. Viruses move at very fast pace, you know.
Mm-hmm.
Evolution is going to work how it's going to work. But you're absolutely right. You know, that narrative of kind of like who's to blame almost takes over for the narrative of like, well, we also left, you know, millions to die because we said that because they had AIDS, they didn't really, you know, deserve help.
Right. And we are still leaving thousands to die because we can provide, you know, AIDS drugs to rich countries at even fairly low prices to consumers sometimes, asterisks sometimes.
I have friends who live in Miami who can't afford their HIV
Right.
AIDS drugs. I have friends who live in Mississippi who can't drink their water or afford their HIV AIDS drugs or afford to go get their blood work done even. You know.
Well, this is what we're going to get to. We've talked about this in terms of surplus populations on a world scale, and I think that's vitally important. But I've been thinking a lot also about the way these world systems replicate within the country. When you talk about healthcare crisis, to me, ground zero isn't even any major city. Everyone talks about violence in Chicago, but if you want to know the most violent, most polluted, most you know, on the forefront population place in America is Jackson, Mississippi, which is got a double whammy of being almost completely black and brown and being in the poorest state, or depending on the year, in the country, right? And even in a lot of healthcare discourses, I don't hear those kinds of areas talked about. And they have knock-on effects because violent crime in Jackson, Mississippi is roughly equivalent to that of Honduras, which is something like 60 times the national average. Now it's a small population area, and I'm always hesitant to talk about crime stats because people interpret them in xenophobic ways, but all this is tied together, and it's here. It's within our borders. It's in a clear place. It's in a place that we're finally kind of paying attention to because yet another water crisis. But it seems like these water crises in mid-sized cities in, you know, the South and the industrial Midwest are becoming like an every year event.
Yeah, no, I mean, I think it's important when it comes to like understanding like how like, you know, crime and like health, so to speak, come together, right? Like, I think it's telling that a lot of the data that we have on some of the most abandoned populations in the United States comes from so-called crime statistics.
Mm-hmm.
Right. There is much greater investment in the infrastructure of carceral containment, incarceration, policing. We have made decisions about how we'd like to fund our states and municipalities that prioritize funding the state through the building of carceral enclosures. And if you build them, then they will be filled. And that provides a kind of baseline revenue, right? And this is an important decision that was made for the fiscal survival of future generations, so to speak, right? The kind of idea of like, oh, we got to keep the deficit down and we got to, you know, keep spending down. But what this is what Ruth Wilson Gilmore calls organized abandonment, which is where the state constructs a capacity to harm. You know, the state's not going out and it's like, I'm going to go like catch a bunch of black and brown people and put them in jail and make jobs that way. Right?
No one, yeah. No one's thinking
but like
that
actually
explicitly.
they are, right? But actually they are at the end of the day, because they're going to make decisions that say, okay, states can't deficit spend. We're going to cut federal spending here. We're going to create laws that allow them to fund themselves through building prisons and nursing homes and psych hospitals and jails, right? There are so many cities in the South where the entire government is funded by the carceral apparatus.
I lived
right?
in one. I'm from Milledgeville, Georgia, in Macon, Georgia, and there were 15 prisons and one giant sanitarium that had been slowly been chopped up to bits because it wasn't profitable. I think it's now officially probably closed. But that was the entire economy of the area plus a university. That was it. There was all the manufacturing had gone. I mean, like, and that's true of, it's even true of places. Okay, you see that in the South, but it's even true of places like upstate New York, like
Pennsylvania, all over the place. This is a decision. California, Washington, Texas, and this doesn't just like also encompass just like sort of the domestic carceral facilities and psychiatric carceral facilities. You also have to remember like the INS facilities and all of the sort of border patrol operations and all of that detention as well. On top of that, this is a ton of money that we put into building jobs and infrastructure and training people and moving resources around. And all of this comes at the explicit cost of abandoning the surplus population that will be at the center of this all, whose bodies will be more valuable as a body in a cell or a body in a bed than anything else to the state. And that was, not the state waking up and saying, I'm going to harm today, but the state making a decision that the only capacity for growth and wealth in our, quote unquote nation is going to be through carcerality, through harms.
I mean, it is often the only thing holding up like ex-urban and rural areas in a lot of the country.
And, I think the future of like our struggles on the left, both for healthcare and for labor at large, are going to require a serious reckoning with our carceral tendencies. We've exported them. We've doubled down on them. We have really sunk so many costs into them. But I think, what more evidence do we need that this is not the way to go than what we've accumulated over the past 300 years so far in the United States, right? And I think it's great because you see a lot of like affinities that are happening right now, where you have people that are like working on, we see this in our server all the time. We have people that are like doing workplace organizing. They're in the reading group. They've got a prison pen pal. Like, they're thinking about the kinds of things that we're talking about in their workplace organizing, in their abolitionist thinking. We're in this moment where I think that kind of like DSA bro approach, right, where you're going to come at it from this really kind of unilateral nationalist worker perspective. I think that's maybe that's a trend on its way out, but I think we've outgrown it.
I hope so. I am arguably personal friends with some of the quote DSA bros, but I also have been worried about it as a tendency for a long time, because a lot of the times that I go and I can just, your book gives me more evidence, but I can just think of things in my own life. Well, that won't work, because you're thinking about it all nationally. Viruses, money, and climate don't respect borders. And the money not respecting borders tends to blow people's mind, but it's also true. I found $1 pretty much anywhere on earth. So that's something to think about. That gives me, though, something to pivot when we talk about the carceral system. And that's your chapter on madness. And I think that's the chapter that is going to push people a lot. One, because while it's not, it doesn't go to the extremes of the 70s with denying madness or psychiatric health as a category, as was often done by people like Foucault and others. Well, Foucault didn't really deny it. He just totally socially constructed it. But there is a truth that, for example, these billing codes and these identities, this is where it really shows up. Like, there aren't pathologies underlying DSM, diagnostic manual criterion. They are agreed on by this American Psychological Association and by insurance companies. And what is in there, what isn't in there is partially decided on what can be paid for by insurance companies at any given time, and what is an acceptable thing to treat someone with. And a lot of the things that they're treating, the treatment works. I mean, whether or not it has a pathology is kind of irrelevant to some of the efficacy of the treatment. But this really shows up in the fact that we've also allowed broad swaths of the population affected by mental illness and madness, as what you use there, to be swapped up almost primarily by the carceral system. That is, for people to know, in the United States, that's the number one indicator if the cops are going to kill you, is whether or not you have a mental health comorbidity and you interface with the police. That more then the racial stuff kicks in, but if you compound the two, oh my God. But if you are mentally unwell and you interface with the cops, which you are almost certainly going to do, your likelihood of getting shot is much, much higher than the general population. And your book goes into this. So would you like to talk about this as our final category? How is this dealing with psychiatric health really problematized right now?
This is a hard one, because a lot of times when you start to critique psychiatric authority, people worry that maybe you're denying the existence of mental illness. And that's because a lot of the people in the past who have critiqued psychiatric authority have said a lot of bullshit, like mental illness isn't real and whatever. There have also been a lot of people who have critiqued psychiatric authority who have been anti-medication, right? And vehemently and across the board. There are concepts in this book that we try and introduce that are definitely easily confused with those critiques. And so we try and tread very carefully. And what we're talking about is essentially what the role that psychiatry has had over centuries, really. And psychiatry is a profession that has gone through many revolutions, actually. There are several psychiatric revolutions, and then that's the terminology that's used within psychiatry, right? And there have been moments of major paradigm shifts, because a lot of what the psychiatric diagnostic criteria is a bunch of observation and consensus, right? We have this idea called biopsychiatry that becomes popular and begins to dominate a lot of the models of treatment. And this happens at a moment where the preferred mode of treating people is to put them in an institution. These were a wide range of facilities. Most of them should be thought of as a carceral facility, carceral adjacent. There are work camps, there are labor camps. There are things essentially where you have moments where, institutions in the US, some of them in the South, I heard of one this week that in the 1920s had 12,000 residents in Georgia, I think it was.
Yeah, it's literally the one I live nearby. I know exactly what you're talking about.
Yes. I think it was the largest
in the world.
United States and it's the United States had one of the largest populations of people who were living their entire lives, most of them. I mean, you're going into a facility and oftentimes you are there for 30, 40, 50 years. Sometimes people went in as children. And there was a very long process called deinstitutionalization. Mm-hmm. And psychiatric revolutions and psychiatric critiques of their own methods and treatment and authority over the years have made a lot of innovations possible that have taken things that were very cruel and maybe kind of cruel and unusual punishment and sought to shape them more towards like an actual therapeutic aim. But the truth of the matter is that for a long time, psychiatry and institutionalization was also used as a way to just remove people from society. And it's fundamentally a logic of who belongs in society and who doesn't. And the kind of amazing thing is that the reason that essentially is supposed to sort of justify this is this very eugenic notion of abnormal people needing to be removed from society in order to preserve the normality of everyone else. It's the idea that madness is quote unquote like ontologically unstable and that it's going to destabilize society. And so what starts happening in the 1970s is you've had a couple decades now of deinstitutionalization work, and you have a lot of left thinkers, both disability thinkers and people in psychiatry, psych patients, mad people's movement organizations who are really thinking through, okay, like what is the point of the kind of framework of psychiatric incarceration that dominates? What is the point of taking someone out and putting them in a facility for 30, 40 years? What does that do? It not only removes them from the community, but it frees up the people in their life to sort of be more productive workers. Mm-hmm. And so we're sort of engaging with that critique, which is that therapy, whatever therapy, regardless of if it's a cancer treatment, a talk therapy, a vaccine, whatever, right? It's only therapeutic if it's being given to someone for the right reasons. And often when we think about who care is for, when it comes to psychiatric care, the person who needs care is not really the main center of our conversation. It's the safety of society. And this is an idea called carceral sanism, which is basically the idea that we think that madness makes us unsafe and is dangerous. And so there are a lot of people like Liat Ben-Moshe who have done amazing work on this. Highly recommend her book, Decarcerating Disability. But essentially, you know, what we try and show is that a lot of the pathologization of dissent, left critique that has occurred over the years has actually happened within the context of psychiatry, that leftist thought has been actually pathologized, and that's also something that we need to consider when we're thinking about what the role all kinds of care have to ourselves, not just as people trying to feel better, but as people who are essentially coerced to pay to maintain our own labor supply. Mm-hmm. And that it's sort of, you know, it's not a rejection of like saying like, oh, fuck your psychiatrist. It's saying like, maybe your psychiatrist would make you feel better if the whole point of psychiatry wasn't about getting someone back to work. If the point of psychiatry was about making the person feel better. And in some individual care relationships it is, but within broader structures, there are different values, again, like the kind of economic valuation of life where we say, oh, someone's a kind of productive or unproductive, high functioning, low functioning, where these ways of measuring who is a kind of good patient or a bad patient, who's a patient that needs to be put in a psych facility, who can live at home, who is safe, who's dangerous, that those judgments that we need to understand that they have an economic context. And that's really very important. And that's kind of what we're hammering home in that chapter.
Yeah, I found that chapter particularly interesting when I think about the psychological treatment of things that are not readily you don't return to work from, or also don't deny you work. And in my own life, I remember on one form of insurance until I started dating someone who was more well off than me. I was subject to one provider once a month for a temporary period of time for any healthcare related to mental health that I had.
Right.
And I got a diagnosis of post-traumatic stress disorder, and they were immediately like, well, we can't even begin treating you for this because there's no way they're going to cover it all.
Right.
And so when I read that chapter, I'm like, yep, I've been there. And I've also been, I've been sort of in the middle dial between the people who were the psychiatric deniers, and then people, and then like, no, I'm like, mental health is real, but a lot of these diagnoses are thinner than you think and are more politically or financially motivated than you think. And we do have to recognize that. There's a reason why we use drugs to treat depression for such a long time. And it literally took 2 decades of that not working for 60% of the population that was subject to it for the modality to finally change. And the reason why is primarily about getting people back to work and just saying, fine, if you can use some positive psychology or whatever, we'll do that, as opposed to throwing drugs at you, because the drugs aren't getting them back to work anyway at this point.
Well, and I mean, not to like be like, and it actually gets bigger, but fundamentally at the end of the day, you can't separate the efficacy of drugs from the way that we fund research and from the economic valuation of life that underlies all of pharmaceutical research and investment. Because the drugs that we have now, and anything we could say about the drugs we have, they're, yes, critiques of pharmaceuticals, but they're more critiques of the value systems that produced the specific drugs that we have, right? And there are many examples. You brought up Cuba earlier of, independent drug development that has gone on throughout history. We bring up one example of a way that a scientist sort of figures out to like synthesize hormones, and the gymnastics that the United States basically goes through in order to make sure that like this Mexican company gets cut out. And that they can only enter the international market once they've made an agreement with a larger drug company that has international standing. So it's the idea that this kind of ingenuity and talent is something that's only in the global north, or that like pharmaceutical innovation only comes from America and Europe. Like, that's just bullshit. That's just where the money is being spent, right? And so I think, we can talk about like the right ways to treat depression and the ways to fund depression treatments that we have now, but we also can't like separate that from the fact of like, well, all of the things that we have only because those are the things that have been able to get funding to be studied, right? Yeah. So the stuff that we talk about in the last 2 chapters of the book, where we talk about a patient group called the Socialist Patient Collective, or SPK, they formed within a research university hospital when their treatment was taken away. These weren't people that were like, let's go organize together. Their treatment was taken away, and they organized to try and get it back. And they pushed it further, and they decided they wanted to study themselves, and they pushed the university, and they did direct action to force the university into a position where they were offering them some funding and the opportunity to investigate forms of therapy that were supported by their medication protocols that might be more oriented towards making them feel better and not just towards recertifying them for work. And they were criminalized by the West German state thrown in jail. I mean, there's a whole part in the end where we talk about Deleuze and Guattari coming for the trial, and it's like, you know, essentially this big international movement of, you know, psychiatrists that have all been talking to each other for decades now doing this work. Like only 20 of them show up to support these patients that are being criminalized who are part of their project. And, you know, it's kind of a sad story, but I think it's another lesson that we can't be thinking of any of our left political theory like as something that like is necessarily contained within our borders.
That's a great point to end on. I have gotten a lot from your book. I'm very looking forward to seeing it out. I think
Thank you.
It touches on things that will break people out of some very staid and easy political context. And I know the other issues that tend to do this are around climate change, but like I've been saying this entire podcast, quit thinking about those things as separate. Like all this stuff is related.
Yeah, absolutely.
Check out, I would tell everybody to go check out Death Panel. I'm a patron as of today. I really, really, really think that you and your co-author and your co-host are doing some important work. So I hope people share it. This episode was requested by a patron of mine, actually. So I would like to thank her for bringing you to my attention, because I began about 3 months ago going, I need to cover more of healthcare. Like that this is a problem on the left that is talked about very superficially. And I've discovered you and a couple other shows that cover it in more depth, but I just wanted to give you a plug. So anything would you like to plug on your way out?
No, I mean, I just appreciate it so much. We started Death Panel because we were feeling like there were conversations we really wanted to have that were just not happening. So I appreciate you having me on today to be able to have one of those, because it's, you know, as much as I was joking about like, you know, DSA bros or whatever, you know, these are the kinds of things that I think are going to take anyone's organizing into like an accurate way to move forward through COVID. Our book's not about COVID, because not a single fucking lesson that we have so-called learned from COVID was anything new. We knew this shit. We've known this shit. It's time to start thinking about these questions relative to all the other stuff that we're working on, because at the end of the day, like the rent-seeking economy that we have with our own labor power is something that we're going to have to address if we want, you know, to support workers in any capacity at all. And not just workers, also the surplus, of course.
Yep. Yeah. Thank you so much for coming on. Have a great day.
Thank you so much. It was nice to meet you.
Let's meet you too.